Okay, well, good afternoon, everyone, and welcome to teaching today. Today, I wanted to talk about a topic we haven't spoken about before in these lectures, and that's hearing loss in children. Um, it's uh, it's it's surprisingly common, and and I think often neglected and under-recognized, and it's a has major consequences for neurodevelopment and language development and cognitive development and school performance and a whole lot of other things that are really important to child development. So, as pediatricians, we really need to understand hearing loss and identify it more frequently and manage it as best as we can. So, this is how common it is. I mean, at least. Around about 1% of all children have some form of congenital hearing loss. It might not be profound hearing loss, but some form of congenital hearing loss. And there are congenital syndromes, there's genetic causes of hearing loss, and then there's acquired intrauterine causes of hearing loss, such as intrauterine infections, which we'll talk about. But more commonly than that is the children that don't have hearing loss at birth, but acquire hearing loss throughout childhood. And that's most commonly due to chronic serous otitis media or recurrent otitis media that leads to infection and fluid buildup in the middle ear and then eardrum perforation and chronic discharge from the ear. That's the most common cause of hearing loss in the world. And that comprises somewhere between 2 and 10%, depending on the population. Children that come from countries where there's very high rates of pneumococcal and Haemophilus colonization of the nasopharynx, and where there's high rates of bacterial infections such as otitis media and pneumonia, they're more at risk of getting chronic serous otitis media. And in those countries, the rates are higher, somewhere between 5 and 8%, even up to 10%. And then those infections are also liable to increase the risk of getting mastoiditis and intracranial infections like meningitis. So when you combine all of that, somewhere the acquired hearing loss occurs somewhere between 2 and 10% in children, especially in countries where those sorts of upper respiratory tract infections are more common. So when you add it all up, around about 5 to 10% of children are likely to have some form of hearing loss, and it does affect their language development and their overall neurodevelopment in a profound way. As I said, the most common cause of isolated hearing loss that leads to speech delay is chronic serous otitis media. And then there's a few other forms of acquired and congenital hearing loss, like ototoxic drugs, especially when given to preterm babies. They're more at risk of ototoxicity. Some babies are born with outer ear anomalies, so anomalies of the outer ear, including the ear canal, and then, as I said, congenital intrauterine infections, including rubella and cytomegalovirus. Cytomegalovirus is the most common cause of intrauterine viral infection causing hearing loss in children, and it's often not tested for, and it's remarkably common. And then also toxoplasmosis, which is less common. Congenital rubella is less common and, of course, causes a lot of other congenital abnormalities. CMV, congenital CMV can just cause isolated hearing loss without any other problems. And then, as I said, there's some genetic causes, and there's a whole variety of genetic causes that can cause hearing loss and or profound deafness. One of which um, is some of which are associated with syndromic changes, phenotypic changes that are recognizable, and then some of which are not. So Alport syndrome, for example, is a form of deafness that's associated with some um, ocular lens abnormalities, lenticonus, which is where there's a conical shape to the lens of the eye, which you can see with a slit lamp. You can see it tangentially, the conical shape to the eye. And there's often a history of progressive renal impairment, but usually in sort of teen and adult life. And so the children have deafness, but they may develop kidney failure later in life. And it's X-linked, so there's usually males more affected, predominantly males affected, and there's in the family history you'll see both deafness and kidney failure. And then there's a variety of different causes of hearing loss, not just with isolated speech delay, but with global developmental delay. And of course, those congenital intrauterine viral infections or neonatal meningitis or kernicterus, they can all cause more general global developmental delay. Children may have cerebral palsy or other sensory abnormalities like visual abnormalities with deafness. So if you see a child with global developmental delay, it's very important that their hearing is assessed. And if you see a child with isolated speech delay, then it's very important that their hearing is assessed. Uh, Some other genetic syndromes, such as Down syndrome and CHARGE, which I'll mention later, they're also very commonly associated with hearing loss. So when we're thinking about the children that should be screened or properly tested for hearing loss, then it's important to know the types of conditions that are associated with hearing loss. I wanted to, so you might understand this already, but I wanted to try to describe um, the severity of hearing loss and how it's tested and the difference between nerve and bone conduction and what that means and how it's typically tested. So hearing loss is sounds are measured in both volume and or intensity and in frequency. And if hearing loss is only mild, we normally can hear sounds of less than 10% decibels. They're just whispers or very soft sounds. If hearing loss is mild, then you lose those the ability to hear those sounds. Mild hearing loss is 20 to 35 decibels. Again, whispers, soft voices, that sort of thing. Moderate hearing loss, 36 to 50 decibels. These are all convention, but there's 5 different categories of the severity of hearing loss. Moderately severe, 51 to 65 decibels. Severe hearing loss, 66 to 80 decibels. If you've got severe hearing loss or moderately severe hearing loss, then even loud voices or shouting you may struggle to hear. And then profound hearing loss, 81 decibels or higher, which is the threshold for the sound the loudness of the sound that you can hear. The softest sound that you can hear is your threshold, right? So if you can't hear whispers or you can't hear people talking, then likely you've got mild or moderate hearing loss. For children, regardless of whether one or both ears is affected, I mean you can have a different level of hearing loss in the 2 ears, or you can have one ear that's normal and one ear that has hearing loss. But even if you've got one ear that is moderately or severely affected, then that can have a substantial effect on a child's language development. As I said, the speech range, just whispers are like 10 to 30 decibels, and shouting is 80 to 100 decibels. And so if you've got severe hearing loss, then all you can hear is shouting. You can't hear normal tone voices. You can't hear people whispering to you. Many sounds you won't hear. Normal conversations around 60 decibels. That's it. So I've talked about this, and I think it's important that we can understand an audiogram. An audiogram measures both domains of hearing, and that is the volume of the sound, the intensity or the loudness of the sound in decibels, and that's on the y-axis. On the x-axis is the frequency of the sound, and I'll explain what that means. Um, so the y-axis is the loudness of the sound in decibels, and as I said, low decibel or low intensity sounds include whispers, even getting to moderate intensity sounds, normal talking. High intensity sounds are like shouting or machinery being used. A jackhammer is a loud sound. Police siren, that's a loud sound. and that exists at very high decibels, more than 100 decibels. As I said, the x-axis measures the frequency or the pitch of the sound. And you can think about like thunder is a sort of a low frequency sound. It's the background roar of thunder, or a frog croaking, that's a low intensity sound. Whereas high intensity sound, let's see, an umpire's whistle, birds singing, children's voices, high pitched sounds like that. Most telephones, that's a high frequency sound. And so you can understand um, hearing loss in those two domains. One, the loudness of the sound that is lost, and the frequency of sound, or the loudest sound a person can hear, and the frequency at which that volume of sound is lost. And you can understand that therefore in the left and the right ear. And that's what an audiogram is. It graphs both the hearing level in decibels and the frequency and the left and the right ear. And then it can also graph both nerve conduction and bone conduction. And I'll explain that in the next slide. But this is an audiogram of somebody who has in the left ear being the blue lines with crosses, the left ear, there's normal at low frequency sounds, the person can hear normally. It's only at quite high frequency sounds in the left ear that there is a loss of a mild loss of hearing. Whereas in the right ear, there is hearing loss at even low frequency sounds. Yeah, in the right ear, there's hearing loss at low frequency sounds, and that's at a moderate degree throughout um, the intensity of sounds, and then more so at very high intensity sounds. So there's greater hearing loss in the left ear, in the right ear than there is in the left ear. So the person can hear more better from their left ear than they can from their right ear. But at high intensity sounds, both ears can't hear as well as what they can at low intensity sounds. So this person would struggle to hear high pitched sounds. They wouldn't hear well high pitched sounds or high frequency sounds, bird song, that sort of thing. Whereas they will be able to hear normal talking. Right? So just understand those two domains, the intensity of the sound in decibels, the frequency of the sound measured in hertz, the left and the right ear. And then there's the concept of nerve conduction and bone conduction. And these two things are quite important because you can, from the audiogram, you can understand what type of hearing loss a child might have. And the traditional way of doing it is with a tuning fork, isn't it? Called Rinne's test. And Rinne's test tests for both um, air conduction, which is really testing two things. It's testing whether a person can hear the tuning fork when it's held outside the ear. So there has to be air conduction. It's going through the outer ear canal, through the tympanic membrane, through the middle ear and into the cochlea. Then you know that all of those apparatus are working, and that there's unlikely to be a hearing limiting effusion in the middle ear. Right? If the person um, can't hear through the air conduction, but can hear through bone conduction. Bone conduction bypasses the middle ear and it goes directly to the cochlea and to the nerve cells, the hair cells in the cochlea, and then to the auditory nerve. So if a person can only hear through bone conduction but can't hear through air conduction, then it's very likely that the middle ear has an effusion or there's some problem with the auditory canal. It might be too narrow, congenitally narrow, or it might be there's a middle ear effusion, or there's a hole in the tympanic membrane, and so therefore the person can hear well through nerve conduction but can't hear through bone conduction, and that's shown up in the audiogram as well. So as I said, This is one ear, not two ears, but if, for example, in this example, the person can hear adequately, like they have good hearing, not no decibel loss through bone conduction, but through air conduction they have a moderate level of hearing loss, then it's likely they've got a middle ear effusion. And that's the typical audiogram you see in a child who's got chronic serous otitis media. In this case, in this other case, the second case on the right side, there's equal loss in both bone and air conduction, and it's only occurring at high frequencies. And so this is most likely if you've got equal loss through bone and air conduction, then it's likely it makes sense that if there's equal loss through bone and air conduction, the sound is getting through the outer ear canal, through the tympanic membrane, and it's not being detected at the cochlea. And similarly, the sound that's generated through bone conduction is not detected at the cochlea. There must be a problem at the cochlea or central, some sort of most likely sensory neural hearing loss. And you can see that this person has lost hearing at mostly at high frequencies. Not so much at low frequencies. They can hear low frequency sounds okay, but at higher frequencies, there's a loss of both bone and air conduction. And that sort of hearing loss is, for example, rather typical of aminoglycoside toxicity, where you typically lose hearing, you lose hearing based on sensory neural hearing loss at high frequencies, but not so much at low frequencies. So that is from an audiogram, you can interpret what the likely pathologies are, or in fact where the pathology is, whether it's at the external ear or the middle ear, or at the sensory neural hearing loss. I wanted to talk a bit about ear pathology, and even though mostly this is the domain of ENT surgeons, we really need to understand it well because it affects, as I said, lots of aspects of language development and overall development, and it's really common. And so, at some stage in a child's life, they'll have what we call glue ear, and glue ear is not chronic serous otitis media. It's just there's been some infection leading to a build-up of, usually leading to two things: a build-up of fluid in the middle ear, and also an obstruction to the eustachian tube. And the eustachian tube usually drains the middle ear to the back of the throat. But if there's a blockage of that because of swelling or because of allergy or an infection, mucus blocking the eustachian tube, then fluid will build up in the middle ear, and that leads to this concept of glue ear, and the middle ear canal becomes full of thick and viscous or sticky fluid behind the eardrum, and you can see it in on otoscopy. You can see the fluid build up behind the drum, and that leads to ear pain, a feeling of fullness in the ear. Children, if they can communicate, have a problem with balance, and they have temporary hearing loss in that ear. It's usually temporary, and usually it goes away within a few months. Sometimes the quite often the eustachian tube is blocked, and you can do some things to try to unblock the eustachian tube and help the middle ear drain, but usually that fluid will resolve within a few months. But the child, the child has a few months where they're not hearing in that ear, and that can significantly delay their language development, especially if it's recurrent, if they get recurrent glue ear. It's very common in children. One glue ear affects, yeah, more than half of all children at some stage by the time they're 5 years of age. It usually doesn't have a major effect on language development because it resolves after a few months, but it can do if it's recurrent. I've explained this in in words, but in details. The fluid buildup is in the middle ear. So the inner ear, the middle ear, and the outer ear. And the fluid buildup is in the middle ear where the glue is, if you like. And the glue is also obstructing the eustachian tube, or sometimes it's obstructed by edema. So this fluid can't drain as it usually does from the middle ear. When if this persists, and especially if it's associated with a secondary bacterial infection because of stasis of the mucus, and partly because of if children are colonized with bacteria in their nasopharynx, heavily colonized, and if you get a chronic infection in the middle ear, and sometimes with perforation, then it can lead to chronic serous otitis media. As I said, glue ear usually resolves over a few months, but if you get a secondary purulent bacterial infection, then this is what chronic serous otitis media looks like. A bit different to glue ear. You can see a sort of perforation. You can see the pus behind the drum, and this is very common in children in many countries. And the risk factors seem to be the sort of risk factors that we see for children who've got recurrent bacterial pneumonia, for example. So if they get recurrent upper respiratory tract infections, if they're colonized with pneumococcus and Haemophilus in their throat, or they're colonized with other bacteria that can cause this, including Pseudomonas. It's a relatively common cause of recurrent chronic serous otitis media. In overcrowded housing, again, it just these bacteria circulate more commonly. If families are not, they don't have water for hand washing, that's a big issue. If they don't have running water in the house and they can't wash their hands well. In some countries, swimming in unclean pools or swimming in unclean waterways or even community pools can be a risk factor for chronic serous otitis media if the pool is not chlorinated and clean. And that's because the child is submerging, and if they have a perforation, then they get water in the middle ear, and that can get infected. Exposure to smoke, so in any indoor air pollution, but especially exposure to cigarette smoke is a risk factor, and lack of breastfeeding, just because you're less likely to get respiratory viral infections, and therefore less like that's the start of it. A respiratory viral infection, it leads to a bacterial infection, it leads to infection in the middle ear, a buildup of mucus, and then a chronic infection with a bacteria, either pneumococcus or Haemophilus or Pseudomonas, and then a perforation of the drum, and then this chronic infection that occurs. So again, very, very common. It is a spectrum between acute otitis media that either resolves completely or resolves with antibiotics, and glue ear, and then to chronic serous otitis media and purulent draining ear that might be infected with another bacteria such as Pseudomonas or Haemophilus, and then these children, when children have a perforated drum and they've got chronic serous otitis media, you know that their hearing loss is going to be quite severe and it's going to last a long time. I just wanted to show you some tympanograms, and this is a normal tympanoscopy. You can see the angle of the stapes and a normal, like it's quite a shiny drum. It doesn't look like there's a fluid buildup behind it. Whereas this is acute otitis media. It's inflamed. The drum is injected. It's a bit retracted. In fact, it's a bit bulging, and then there's a retraction to the eardrum. You can see the fluid behind the ear in the lower part. It just looks very inflamed and red. And this chronic serous otitis media, you can see the pus behind the drum, and then serous otitis media with scarring. This is a chronic infection where there's been several perforations of the drum. There's then fibrous scarring of the drum to heal it, but the child still has a purulent discharge from the ear. So it's a spectrum that not too many children reach this point, but enough that it's a big problem when they do, because you know that they're going to have a substantial hearing loss for a long time. The eardrum's not going to work because they've got a scarred eardrum that's not vibrating as it should when sound is experienced. The treatment for these things, again, it's a spectrum of treatment. Glue ear usually gets better by itself over 3 months, but that's 3 months of not hearing well in that ear. If it's bilateral, then the child will be significantly impaired and language will be quite delayed. If a child's got acute otitis media, then antibiotics are right, but not prolonged antibiotics. Don't give these children continuous antibiotics for weeks and weeks or months. It's not all that'll do is lead to resistant bugs such as Pseudomonas in the ear and increasing the risk of chronic serous otitis media. Sometimes if a child does a Valsalva maneuver, they can help to drain the inner ear if they're old enough. And some nasal decongestants can open up the eustachian tube and allow the fluid to drain. That can be quite useful, eustachian tubes. And then sometimes ENT surgeons will put in grommets, which are aeration tubes, little plastic tubes that allow the fluid to drain out from the middle ear into the outer ear. And all that does is enable the fluid to drain and allow the infection to heal a little bit quicker and for hearing to be recovered a bit quicker. And so the child, instead of spending 3 months without being able to hear from that ear and having a feeling of fullness and pain in the ear, then they get quite good relief from aeration tubes that drain the ear. And then there's children with chronic serous otitis media, which again, most children with glue ear don't get chronic serous otitis media, but if they do, then the generally the accepted treatment is topical antibiotics. Systemic antibiotics have some role, but fairly um, limited duration of systemic antibiotics, not for weeks and months, similarly. But topical antibiotics, especially those antibiotics that will cover both pneumococcus, Haemophilus, and Pseudomonas, so topical tobramycin or topical gentamicin or ciprofloxacin, the ciprofloxacin drops that's quite good for chronic serous otitis media. But at the same time, you have to try to keep the ear dry. It's no point giving antibiotics if you haven't got a dry ear. And so there is a way to, it's called wicking, which is just using very clean, absorbent paper and drying the pus from the outer ear can be helpful. Sometimes with chronic serous otitis media, eustachian tubes are put in, grommets are put in it to aerate the ear, but usually the ear is draining by itself because there's a perforation in the ear. If children have got a perforation or if they've got a pus, fluid draining from the ear, then they need to avoid submerging in water, especially in unclean water, and should avoid prolonged systemic antibiotics. There's been no evidence that prolonged systemic antibiotics are of any benefit in chronic serous otitis media, so really try to avoid them. There's lots of problems with prolonged antibiotic exposure, resistant bugs being then colonizing the ear or the throat, side effects of drugs like diarrhea, and then the effect on the microbiome, which is really under-recognized, I think, when children are exposed to lots of antibiotics. I'm going to move on from infective causes of hearing loss to just a few of the congenital forms of hearing loss. And we've talked before about congenital rubella syndrome, but those children, of course, are likely to have other features that can enable congenital rubella syndrome to be detected, such as cataracts. They have sensory neural hearing loss, not conductive hearing loss. They often have congenital heart disease, as you know, and microcephaly, and they may present with a rash and hepatomegaly or splenomegaly, the typical features of the intrauterine viral infections, or the sometimes called torch infections, torch congenital infections, cataracts, a rash, again cataracts there, and in a low birth weight baby with micro. Congenital CMV infection is the most common intrauterine virus causing deafness, and as I said, it can cause other things like visual loss and developmental delay, all the features of congenital rubella syndrome, but it does also cause deafness in the absence of those things. And so if you see a child who's got hearing loss, then and no other features, then they might have congenital rubella syndrome, but they also can have these other features as well that are common to congenital rubella syndrome and other intrauterine viral infections. There are some other congenital syndromes associated with deafness typically, and Apert syndrome or craniofacial syndromes are relatively common in Papua New Guinea. There's a number of families with this syndrome. These kids are often, their brains are often quite normal, but they have bony sutural synostosis or bony uh, their bones are fused early, and they and also it can also affect the bones of their outer and middle ear. And these children, not always, but often have deafness. It's really important that these kids are screened for hearing loss because they can improve if, for example, if they've got only stenosis and not atresia of the external ear canal, then they can improve, for example, with by keeping that patent and sometimes by hearing aids and other things. Yeah. Charge syndrome is another relatively common congenital syndrome that is associated with deafness. And unlike kids with Apert syndrome, usually their outer ear is malformed, and they have some other features that are quite important too. Collobomas of the eyes and ear abnormalities are the common features that children with Charge syndrome have. As you probably know, Charge syndrome leads to it's not all children have all of these features, but some children have all of them, and some children just have some, including collobomas of the eyes, and they're just defects in the pupil of the eye and in the in you can see the defect there, a larger pupil or a smaller pupil or a pupil that's deformed in a way or has a pit or a narrowing of the pupil. That's a coloboma. And heart defects relatively common in children with Charge syndrome. That's atresia of the nasal choanae, so choanal stenosis or choanal atresia. They often have retardation of growth and development generally, intellectual delay, although some are not too delayed. Often genitourinary abnormalities and kidney problems and these ear abnormalities, and they children with Charge syndrome often have severe conductive deafness, atresia of the external ear canal, and anomalies also of the inner ear, such as anomalies of the cochlea and the bones of the inner ear, and that leads to, in most children with Charge syndrome, to a mixed sensory neural or conductive and conductive hearing loss because of both the external ear canal and also the inner ear is affected. And another cause of I've touched on this before, but it's quite important to understand the type of hearing loss that occurs with aminoglycoside toxicity, and it usually occurs when children are exposed to high prolonged levels of aminoglycosides, and that damages the cochlea, particularly the hair cells of the cochlea. Aminoglycosides are concentrated within the hair cells of the cochlea and can cause toxicity. It's a form of neurotoxicity that affects the hair cells, and it especially affects the cochlea at the base of the cochlea, and that's where the high frequency sounds are detected. And that's why the audiogram will look like this. At low frequencies, there's limited or no hearing loss, but it's only at higher frequencies, very high pitched sounds. These children won't be able to hear, and that's a typical audiogram of a child who's got aminoglycoside toxicity, and commonly this occurs in preterm babies that are susceptible and have been exposed to high levels of aminoglycosides in early life. So very important to limit the use of aminoglycosides in preterm babies, especially if the levels can't be measured. So I've talked quite a lot. I hope from this you'll understand that hearing loss can affect children from in all different ways and in from all different causes. And so we need to sort of have an idea of which children should have their hearing tested. And so all children with language delay, they should have their hearing tested because it's probably it's the first most important cause of language delay. If the parents say the child can't hear, that's a red flag. The parents are usually right. They're the ones who really that would know if the child can hear or not. And so if they say they're worried about the child's hearing, then they should be tested. And any child who's got chronic serous otitis media, they need to have their hearing tested. If they've just got glue ear and it resolves, then it's not usually necessary. Usually, as long as there's no other red flags, they've got language delay or their parents if their parents think they can hear okay and their language is all right, then they don't need to be tested. But if they've got chronic serous otitis media, then they should have their hearing tested. And then they're the common ones. Then bit less commonly, preterm babies, especially if they've been exposed to aminoglycosides, need to have their hearing tested because many months can go by before the language delay, even years can go by before the language delay that occurs because of hearing loss is identified, and that can really set a child back. If there's a family history of deafness, I talked about Alport syndrome and other congenital problems, inherited problems related to deafness, that those children need to be tested. If they've got a congenital ear abnormality, if their outer ear if they've got microtia or an abnormality of their outer ear, then they may have an abnormality that's affecting their hearing of the inner ear. And all infants with signs of intrauterine viral infections, the so-called torch infections, that they also need to be tested as well. Children post meningitis, they should also be tested because meningitis is certainly sensory neural hearing loss occurs in around about 8 to 10% of all children with meningitis, and usually by the time a child gets discharged from hospital after meningitis, you can't always tell that they've got sensory neural hearing loss. You might be able to detect they've got some hearing loss, but they might just have an inner ear, a middle ear effusion where the otitis media started that led to their meningitis, and that might resolve. So usually we recommend testing all children with meningitis at 6 weeks because by that stage their middle ear effusion should have resolved, and you can test to see whether they've got a sensory neural hearing loss. We've talked about this before, but giving steroids to children with acute bacterial meningitis reduces the risk of bilateral sensory neural hearing loss. So it's quite proven to be effective, but it still only reduces the risk from 8 to 10%, which is what it used to be, down to a few percent. So those children still need to have hearing tested after 6 or 8 weeks post meningitis. There is I've talked about the way the children that get hearing loss, and we've talked about the physiology. I wanted to talk just briefly about the technology that can help children hear. And certainly it's not these technologies are widespread now and they will be available more commonly, and it's good to understand just what they are. So hearing aids are available, and they're simply an amplifier. They have a microphone that detects sounds, a processor and a receiver that receives the sound, a battery, and they can amplify sound. So to have if you've got mild or moderate or even severe hearing loss, but you've still got some hearing, you've got for a hearing aid to work, you've got to have some hearing because what the hearing aid does is amplify the sound that can be heard. It's this concept of residual hearing. Whatever's left, a hearing aid can amplify that sound. Now, it's if you've got complete hearing loss, so rarely some children have complete hearing loss, profound hearing loss, often a hearing aid won't help them. But if a child has moderate or severe hearing loss and they've still got some residual hearing, then the amplification of the sound that they can hear can help, especially their language development. And hearing aids can be given at, can be uh, used at any age, even infants. The only problem is getting them lost. But there are ways now you can secure hearing aids to the ear, and many infants, if they're detected with hearing loss in older infancy, or um, then they can wear a hearing aid to amplify the sound. It's important with children's hearing aids that they have a secure battery case because hearing aids contain a lithium battery for adults and for children, and that's very dangerous if a child happened to swallow it. So most hearing aids for kids have a very a child-proof battery case so that the child couldn't get the lithium battery out of it. I just want to touch on you'll hear about this, a cochlear implant, and it's different to a hearing aid. And this is technology that's being used in many countries now. It's not widely available in some other countries, but for children who have severe or profound hearing loss, where a hearing aid is not enough, it can't, there's not enough sound to amplify, then a cochlear implant can work. And what a cochlear implant does, it's a bit like bone conduction. It bypasses the middle ear, and in fact, it even bypasses the inner ear and goes straight to the auditory nerve. And so the uh, the cochlear implant detects signals for sounds, electrical impulses, and then transmits them directly to the auditory nerve. And so all of that work of hearing that goes on with the external ear, the middle ear, and the inner ear is bypassed. And so cochlear implants can be used in children that have got severe or profound hearing loss, and they will hear sound quite well. Um, so if there is a child with that degree of hearing loss, then they can be useful. Yeah. Okay. There's some other ways in which children with hearing loss can be managed. Firstly, treat chronic ear infections in conductive hearing loss, and get the ENT surgeons to drain them, etc. There's other ways in which children can adapt if they can't get hearing aids, and certainly can't get a cochlear implant. Then using sign language can be useful, and there are ways to learn Auslan, which is a it's a widespread sign language. It's a very complex language that kids can learn very well, even at a very young age. In the same way that children can learn speech, they can learn Auslan or sign language. Again, very complex language. It's not just simple signs. These are very complex signs that kids can learn, and they get very good at it. And then text messaging, a variety of different ways, digital ways now that children can communicate, even if they are profoundly deaf, as you can imagine. So look, that's all I want to say today. I wanted to just cover hearing loss because it's more common than what we think, and that important to know the types of children we should be testing for hearing impairment, and what to do about the different forms of the different types of hearing loss. So I'm going to stop there, and I'm happy to answer any questions that you might have. Thanks.